Welcome to the 8 Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome back to the 8 Minute Rule. I got Drew and Mark with me. What we're going to talk over today, something that Mark had brought up that I think anybody that has treated patients in the outpatient space has dealt with, on really kind of looking specifically at that patient that maybe is not getting better, and you've had conversations around lifestyle changes, smoking cessation, really eating better. They're just not going to do it. You've had conversations around frequency. They're not willing to come in the amount of times that you want to see them. Maybe you're giving them 3 exercises and they're doing 1 every other day, but they keep coming to you and they keep showing up. And so you're kind of in this weird grounds where you want them to get better. You're feeling like they are not showing that to you. So really, we just want to talk a little bit about how we start to have that conversation. I think when you look across the board, this type of patient exists out there, even with high copays, high deductibles, things like that. We still see this patient show up. And so it's a drain. It probably drains us a lot more than we realize. I know I have a lot of conversations with them, with younger and older clinicians. So, obviously between you guys, I know that we've probably got some pretty good pearls to offer here. Mark, why don't you start us off, man? How does that conversation start for you when you've got this patient that shows up probably 10 minutes late and you're trying to have a conversation about creating more of a direction that you want to go on to be productive?
Yeah, so those are all definitely good examples. There's also the patients that were told by somebody, whether it be an MD or somebody else, that, ultrasound is the thing that's going to get them better, or they've got these kind of preconceived impressions on what's going to get them better, and it's not based in any, credible evidence. Those are the ones that I have the most trouble with because, when you look at the pillars of evidence-based practice, patient values is part of it. And so I want to incorporate that into what I do for the patient. But, if a patient's just adamant that ultrasound is the thing that's going to get them better, we try it and they don't notice any difference. That's not something that I want to continue to spend time on, both, for evidence-based reasons as well as, patient outcome reasons. And so the conversation becomes, hey, we've tried this, we're not getting anywhere. These are the things that I think will help get you better, whether that be manual therapy combined with exercise alone, pain neuroscience education, all the above. They're unwilling to, humor me in a sense of like, hey, I don't want to do exercise because it hurts. Well, blah, blah, blah. You can't do anything. Can't do the most basic things that you're expecting from them to be able to do. That's when the conversation becomes, hey, these are, you're not receptive to pain neuroscience education, even in the smallest format. Maybe this isn't the right place for you right now. Hey, we've been spinning our wheels for a while. You tell me when you come in, you're not feeling any different. You're not feeling any better. Maybe we need to explore some other options. And usually I'd like to at least give them some options or have options planned because I don't want them to be stuck in limbo where they're just like, oh, well, I'm hurting and I'm, never going to get better. But, the conversation is, maybe you need to go see a massage therapist. Maybe you need to, go back to your referring provider. Maybe you need to do something else. But, then I'm happy to help you. I'm here for you. I want to help you. But it sounds like right now, physical therapy isn't really the thing for you. When that changes, when you get into a place where you're willing to hear the education about pain neuroscience, when you're ready to try some exercise in a very low manner to start with to decrease threat, all of the things, please give me a call and I will get you back in. But right now, it seems like we're not really getting anywhere. And I kind of just leave it to them at that point. Most of the time, they're like, "Yeah, I agree. We're not really getting anywhere." And then that changes the conversation to something else after that.
So it sounds like, especially for you, attacking more of the, hey, this patient came out with an expectation of something was going to get them better and it didn't. And you're trying to shift focus and, just pointing to the realistic picture of, you see this isn't working. And so maybe, this is a patient that doesn't have 27 other providers that they're working with, but the open possibility that you can bring other people into the fold there too. So Drew, how about you, man? It can be different situation, it can be same situation, but just thinking along the lines of that patient that is kind of unwilling to change things that you've been trying to drive on. Like what are some conversation pearls that you have?
Yeah, I think something that Mark touched on towards the end is kind of that key, and it's kind of the clinical honesty of, hey, here's what we've been doing, here's what I'm seeing. Are we on the same page that this maybe doesn't seem to be helping? You don't seem to be achieving the goals that you want to get to. You don't seem to be getting significantly better by this. What are your thoughts? And it's not really, you're not placing blame anywhere. You're not really saying, "Oh, well, I've been trying to do all these things and it's just not working because you're not doing this." It's here's the facts, here's what we've been doing. What do you think? And a lot of times patients they'll be like, "Yeah, I agree." And then you get a plan, here's some options. I think where it gets harder, so in a different situation, is when they're like, "Well, when I'm here and you do dry needle ultrasound, I do feel better for a little bit. So I want to keep coming." That's where I think it gets harder because they're like, "Well, I'm going to come, it feels good, and I'll just keep doing that." And that's where the conversation probably becomes something like, "All right, so I'm potentially willing to do that. We have to look at what does that look like usually in a payment model, right? Insurance is not going to continue to cover something where you're coming and getting a little bit better, but then it goes right back. So now here's some other options is I think we can get you to do this for the symptoms to be relieved longer, to progress more. Here's what I feel I need from you. If we can't do that, maybe we do a self-pay thing, right? And if you're willing to do that, there's a lot of times I would probably be willing to do it depending on what their other options are. Because I think there is still some redeeming value in staying out of some of the medicine, the medical stuff, taking all kinds of whether it be NSAIDs or opioids or going down that road or looking for something further. If this is at minimum keeping them what they want to do, I'm willing to do that. I actually have at least one patient who does self-pay, and it's been kind of difficult, but like they come once a week, every other week, and they're not taking a bunch of medications. It keeps them moving enough, and I'm okay with that. I don't feel like I'm robbing the insurance company where they're just going over and over and not making progress. They're willing to pay for it. It keeps them going. They're not on opioids. They are able to go out in the community, they go to their church, they can go fish, all those things. I'm okay with that. Let's keep them
Yeah.
going.
And I think the thing that I've noticed is that like that's a clear communication thing that you've had with the
Yeah.
patient. And like it's, not trying to pretend that it's something different. And I think from the provider standpoint, like, our job, the trans theoretical model of change is, we can try to guide them through that model to make behavior change and everything. But at the end of the day, they have to make the decision and the change themselves. And so like when Drew's working with someone like that, yeah, he'll plant seeds every now and then and try to get them to move through that model and be ready and open to and willing to change. But at the end of the day, he's not losing sleep over it because they have to make that decision themselves.
Yeah, I like where we wrapped it up in that, which is, patient autonomy. I mean, you guys have been around me enough to know that's my soapbox is if we're not creating patient autonomy, then I just don't think we're doing a lot of good for people. And that can go a lot of different ways in the healthcare system. But I think having the conversation around to where the patient feels they're involved and, likewise, yeah, it's the challenge as you're talking about, Drew. Like there's plenty of times where we treat patients and we know, hey, I may not be getting them a ton better, but when I look at everything else that they could be doing right now, it's still the best option. And not from an arrogant standpoint, but just like I know they leave here and it's going to be 20,000 tests, a bunch of money, and they're not going to get any other change there. So I think it is hard to make that decision, but what it has to come down to is the patient communication, creating patient autonomy. I think as long as they're in on the inside and you guys are working together, it's kind of you can have the conversation of, are they sitting across the table from you or right beside you on how we want to approach this? And I think this probably is worth a sit down conversation, maybe in a room for a few minutes with your patient in a session where you're really talking this through because they need to get a game plan on that. And you get to hear some different thoughts of where they are at mentally as well, too, because we tend to put thoughts in our heads around what they're thinking that just aren't accurate. So good stuff. Create patient autonomy. That's a big deal. And it's really going to help us as providers with limiting our burnout, I think. So good stuff, guys. Until next time.